You're listening to the Chemical Sensitivity Podcast. I'm Aaron Goodman. Long COVID has brought millions of people into a reality that many living with multiple chemical sensitivity, or MCS, already know well. Debilitating symptoms, disbelief, difficulty getting a diagnosis, being told the illness is psychological, and the toll of isolation, stigma, and strained relationships. At the same time, many people with long COVID are organizing in unprecedented ways, tracking symptoms, building communities, and pushing for recognition and research. In this episode, we explore what people with MCS and long COVID share, contested diagnoses, medical dismissal, and what scholars call epistemic injustice, when people's knowledge of their own bodies is questioned or ignored. My guest is Professor Deborah Lupton, a leading sociologist of health and medicine at the University of New South Wales in Sydney, Australia, and editor of the recent book, Long COVID and Society, International Perspectives. Please check out and share a link for the podcast's new webpage. It's listen.chemicalsensitivitypodcast.org. It's easy to share with anyone in your life who's interested in learning more about MCS. And please subscribe to the podcast wherever you get your podcasts. To learn more, follow the Chemical Sensitivity Podcast on YouTube, Facebook, X, Instagram, Blue Sky, and TikTok. And you can reach me at aaron@chemicalsensitivitypodcast.org. Thanks for listening. Professor Lupton, thanks so much for joining me.
Great to be here, Aaron.
Yes, would you like to briefly introduce yourself to listeners?
Yes, sure. So my name's Deborah Lupton. I'm a professor at the University of New South Wales in Sydney, Australia. And I'm a health sociologist, so I do a lot of research into the social aspects of health experiences, experience of medicine and healthcare, or experiences of illness. And I also have a public health degree, a Master of Public Health, so I have some training in things like epidemiology and health promotion and health economics and things like that.
And why does long COVID interest you? And you could have chosen to look at anything, I imagine, but why have you chosen to focus on long COVID in such an in-depth way?
Well, from the time that the COVID pandemic became known to the world in early 2020, I actually started writing about it and mapping out a research program for doing research into COVID, because I could see quite early on, as early as March 2020, that it was going to be a devastating illness around the world. And I'd actually done a fair bit of research back in the early days of the HIV/AIDS pandemic, writing about the social aspects of that pandemic. So I already had a background in writing about the social aspects of pandemics, and that meant that I was quite quickly able to see, well, this is a really impactful disease event. I was, noticing what was happening in different countries around the world in terms of different policies about how to manage the spread of the COVID virus. I started doing research about it from very early on. And of course so I've, written a few books, quite a few journal articles about the social aspects of COVID. And so when people started talking about long COVID or long hauler COVID, again, it was quite early on in the pandemic when people, just everyday people, started noticing that they just weren't recovering fully from their first infections from COVID. I also noticed that and started seeing what they were writing about in social media, particularly on Twitter, which I was on quite a lot back then. Twitter in the early years of the pandemic was actually a really great way to share information about both COVID and long COVID. Quite early on the pandemic, I noticed patients talking about it on Twitter. In particular, I noticed medical journal articles starting to be published, often with patients writing about it. because often it was clinicians themselves, medical practitioners themselves, people in the front line of caring for people with COVID who found themselves getting infected with COVID and then realising they had long COVID. So yes, I was interested in the condition from early on.
Most of the listeners are people who have MCS, as well as researchers and clinicians. And I think, like me, they're going to be very interested in learning more about the experiences of people with long COVID. But I wanted to ask you, Professor Lupton, do you ever get requests from people who, like me, researchers or podcasters or students with other contested illnesses who want to know more from you about long COVID, even though we're not talking necessarily about the same illness?
Yes, I do. And when I write about long COVID, because again, going back to my background in health sociology, I'm very aware of the sort of power dynamics around what we call in sociology contested illnesses, or illnesses that the medical profession doesn't take seriously. For example, a few decades ago, when people were trying to get attention to RSI, and a lot of, again, it was a contested illness. So there's quite a few of them around. There have been quite a few of them around, and there's a history of the medical profession not taking those kinds of illnesses seriously because it's often very hard to find biomarkers for them. And so it's often psychologized. It's all in your head. You just need to see a psychiatrist. I'm just been aware from my decades now of research into just health experiences, including contested illnesses, that there's been a long history of them, unfortunately, of the medical profession failing to give the kind of care and acknowledgement to people with those kinds of contested illnesses for a long, long time. And interestingly, there's often a gendered dimension too. So it's often, women have often found themselves even more sort of discriminated against when they have these contested conditions. People of colour too, so it's often the more marginalised you are, the more underprivileged you are, people low socioeconomic status who don't have quite the sort of articulateness or education to challenge the medical profession, older people. If you're in one of those categories, you're even more likely to find yourself discriminated against if you have a contested illness.
Before we dive into the marginalization and the many ways people with long COVID experience marginalization, would you like to talk a little bit about, briefly about what is long COVID and how many people are impacted by it?
How many people in the world have had COVID? How many people have had it more than once? We don't actually know for sure. We can assume, though, that nearly everyone worldwide has had at least one infection of COVID, and many, many more people have had more than one. But these days, most countries don't encourage people to test when even they might have symptoms. There's no longer statistics collected about how many infections there are. I mean, in my country, there isn't anymore, even though we were really good at it in the first few years of the pandemic, asking people to test and asking them to report the test results. So we had a very good handle on it for a long time, but no longer. And I'm sure, and I know that's the case in most, if not all, countries now. So we can't actually put a number on it, because the statistics these days about how many COVID infections there have been worldwide are very, very loose. But we know it's millions around the world. There's also not a lot of reliable information about long COVID, because long COVID, getting back to this contested illnesses, it's a contested diagnosis. There's a lot of debate still, again, in the medical profession, even about what to call it. Now, long COVID itself is a term that people who had continuing symptoms of COVID after the first acute infection, they gave that title. They said, this is what I've got. It's long-term COVID, long hauler COVID, long COVID for short. It basically means symptoms after initial acute infection from COVID that persist. Again, definitions vary. Sometimes it's said to be 1 month after the acute infection or 3 months after the acute infection. but it's several months at least 1 month, if not more, is the medical definition of long COVID, of continuing symptoms that can't otherwise be explained by any other reason other than the fact you've had a recent COVID infection. It's hard to, estimates of how many people have long COVID vary widely, actually. So again, we can't really put a number on it. I mean, I've seen 5%, I've seen 10% of people, I've seen 25%, I've seen 30% in lots of different studies. So let's say it can be anything, anywhere between, say, 5% to 30% of people who've had one COVID infection. But of course, if you've had more than one COVID infection, which a lot of people have had, the risk is greater. So it goes up. The likelihood you'll have long COVID goes up every time you're reinfected. In the medical literature, it is often called post-acute sequelae of COVID, which basically just means continuing symptoms, again, in medical jargon, continuing symptoms after an acute infection of COVID. But patients prefer the term long COVID, which is a patient-made term.
You write that many people with long COVID have had to adapt to a new social reality marked by isolation, stigma, and strained relationships. And this will sound very familiar to people with MCS. Would you like to talk a little bit about this?
Yes, well, the more you read people's accounts of what it's like to live with long COVID, the more depressing it is. And in my book, Long COVID and Society, every chapter that's contributed to the book, apart from mine, actually, as far as I know, I've never had COVID, and I therefore don't have long COVID. I consider myself an ally of people with long COVID rather than having my own lived experience. I'm really vigilant about protecting myself from COVID. I mask up everywhere I go with an N95 and yeah. So anyway, because I do know what the awful impacts are. All the other chapters, either authored by people who have lived experience or co-authored with people who have lived experience. There's a chapter involving interviews with medical professions about what they think about people with long COVID or ME, CFS actually as well. I mean, the attitudes of health professionals who were interviewed for this study, just appalling in terms of, again, not showing much care or acknowledgement of people with both contested conditions. There's a chapter contributed by British sociologists who interviewed families with very young children, in some cases preschoolers, right up to adolescents, who themselves, the children, were living with long COVID. And just the terrible stories you hear of how even tiny children haven't received the treatment and acknowledgement. They haven't received the care. School children have had to take a lot of time off school, and they've found that their schools haven't been understanding. So just the whole spectrum from tiny children right up to older people, the stories that are told in the book by being shunned by family members who don't believe them, that they are seriously ill and disabled, as I said, by schools, by employers, but particularly healthcare professionals. It's given that really it's the mandate of healthcare professionals to show care to patients who come to them for healthcare. I guess I shouldn't say I'm surprised, because as a medical sociologist, I know about the power dynamics and I talk about this in my chapter in the book. The medical profession likes, it's a powerful profession, highly educated people, very high status profession. There's this term called medical dominance in health sociology that's used to refer to the power and authority of the medical profession. I mean, that's the reason we go and see doctors, right? Because we trust them to be authoritative. If we knew what the problem is, we wouldn't go and see a doctor. So,
well, we often do. And I think part of what you write about is that we are increasingly educating ourselves. And there's sort of a pushback against that from the medical profession.
There is, and that's been going on for a long time. I actually did research back in the 90s looking at how both doctors and patients think about this idea of being a health consumer. In the 1970s, there was a big push for people to become more empowered and to sort of seek out more information about their bodies and their illnesses, and to not just accept that the doctor knows everything. Now, that's very well and good, but again, it really depends on your education level, your social class, your age, whether you actually have the ability to feel empowered when you come up against a highly educated, wealthy medical professional.
It can be very intimidating.
When I interviewed Australians in this case of all ages, I often found that, for example, older people didn't want to be consumerists. They wanted to be able to trust their doctor.
Yeah.
They were ill. The health consumerist movement is great for some people, and has been really important for people with long COVID. There are people who are writing about their own lived experience of long COVID with all that education and authority behind them. They're still struggling to be recognised and acknowledged by the clinicians that they see.
You write about epistemic injustice, and I'll just quote you: the struggles of people living with contested, chronic, rare, stigmatized, or invisible illnesses. Could you please talk a little bit about what epistemic injustice looks like for folks with long COVID?
Epistemic means knowledge. It relates to knowledge, how much knowledge people have. And so the term epistemic injustice relates to that, again, that disparity between how much knowledge people have, which relates to how much authority they have when there's what we call a medical encounter, right? A patient goes to a doctor and a doctor relates to the patient. What happens with long COVID and with other contested conditions is that it gets back to what I've just been saying about a consumerist approach, being a patient consumer, that if you don't have the wherewithal to acquire that epistemic authority, clinicians already have it from their training and from the medical authority that they have just by being a member of the medical profession and the status that they have. They have epistemic authority in terms of medical issues, topics.
I certainly feel that authority and the imbalance in the medical encounter.
Yes, and when we're talking about specialists too, as opposed to general practitioners, right? Specialists have had even more training, very long training. I mean, I'm not saying they don't have training. They do have, they absolutely do. They have to go through very long training to be a specialist or even to, complete a medical degree. But what that means is they are authorised by the state, by the university system that they've been through, by the specialist system that they've been through, the hospitals they work for and the associations that they're part of as part of the various specialist associations, to have that epistemic authority. So again, there's an imbalance already when someone who goes to ask for help from a qualified physician, there's already an imbalance there, unless they themselves are a qualified physician. So, and this is where it's interesting, where it's physicians themselves or clinicians themselves or medical researchers, for that matter, with a medical degree who have long COVID. Because they both have the epistemic authority from their medical training and expertise, and they have the lived epistemic authority from living with that particular condition. And for a long time in the medical literature, there's been some really interesting accounts, even before COVID, of, the doctor as patient, and how it's very uncomfortable often for doctors themselves to be in that situation. But also what they often find is they suddenly can see what the patient perspective is, whereas before they couldn't really, Yes. So it's a very interesting combined epistemological position where you have both the medical authority and the lived experience of that condition together. I'm
just thinking about what you've been sharing, and it seems like a lot of the times the physician or the clinician has a different set of information than we have, or they haven't been trained in the condition that we have, whether it's long COVID or MCS. So there's a gap there. So I can imagine, and someone told me once, people don't get it until they get it. And I imagine it might be like that with the physician who happens to get long COVID. They don't get it till they get it. And then if they do, are they able to be more empathetic or supportive or helpful to people?
Yes.
Mm-hmm.
Yeah, the short answer is yes. Mm-hmm. Yes, that comes through loud and clear. Clinicians who, before COVID, had cancer, for example, any other major illness, they just suddenly got it, what it was like to be a patient confronting such a serious illness or disease.
Often invisible condition when maybe they have experienced gaslighting or dismissal. Do you want to talk a little bit about what gaslighting looks like for folks with long COVID? What does that term look like?
Well, gaslighting, it has been used a lot in relation to long COVID, and it's really interesting. It actually comes from a Hollywood movie, I think from the 1950s, which tells the story not of a person with a health condition, but of a woman and it's called Gaslight, and it actually relates to actual gaslights, which is how homes used to be lit, right, before electricity, with gas lights, actual lights made with gas, with lit gas. In this movie, the woman is tricked by her husband into thinking she's going mad. And part of what he does is he makes the gas lights sort of flicker. And she asks him, what's going on? Oh, I don't know, you're imagining it, right? That's where the word gaslight comes from an actual movie involving gaslights. But now it's used metaphorically, of course, to talk about how when people talk about feeling gaslit, it means, and it's usually used in relation to the clinicians they're seeing, that those clinicians, again, psychologize. They say, they literally have often said it's in your head. I mean, they literally have used those terms in relation to contested illnesses, including long COVID. It's go away and do some stress relief, heavy, deep breathing or some kind of, stress, healthy lifestyle, exercise, and that will mean that you'll get better. Because the doctor will say, I don't think it's actually a physical condition. I think it is something to do with your psychology. So that is what gaslighting means. It means people are being told basically, well, not quite that they're mad, but a little bit of, it's all in it's a psychological thing, and they're not being believed that they're actually having physical symptoms for physical reasons.
And this is something that's happened a lot to folks with long COVID, I imagine.
Oh, yes. Yes, they constantly talk about that as part of the social impacts of having long COVID. And again, it's not just doctors, it's family members, work colleagues.
Yeah, and that can be really devastating, can't it? That multiple injury.
Oh, totally. It's extremely devastating, and it makes people feel, well, hopelessness. Comes loud and clear through people's accounts of their experiences. They end up just feeling hopeless about getting any kind of help.
Building on what you've been sharing around the medical encounter, that this can be a form of, you call multi-layered traumatic abandonment, entailing bodily incapacitation, medical neglect, and psychologization, and social isolation, as well as political neglect. Actually, you're quoting Vivian Matisse Boone in that passage, but it's really devastating on a lot of levels.
Vivian Matisse Boone has a chapter in the book, and she's one of those academics I was referring to who herself lives with long COVID, and she's actually a philosopher. So her chapter is a kind of autoethnographic account, which basically means talking about her own experiences of long COVID, but she does so in quite a philosophical way because, that's her academic background. And yes, if you read her chapter, it really does. Every chapter in the book just tells the most awful story about just how people feel like they've just completely discarded by society, abandoned, hopeless again.
Yeah.
Yes.
And there are a lot of parallels for folks with MCS who feel abandoned by the healthcare system, by the political system, and by their families and friends, often their loved ones. Do you see this as a form of trauma?
Oh yes, definitely a form of trauma when you're not believed, when you're suffering. And I think the term suffering is a very relevant term for people with these contested illnesses. They are suffering both physically with the devastating impacts of their condition, but they're suffering from the abandonment at the hands of others.
You write that there's sometimes violence that's inflicted on people with long COVID by clinicians when it comes to situations when they're encouraged to engage in therapy that may not be appropriate or could even be harmful for them. Something that has happened, I know for a lot of people with MCS, we're often told to take prescription medication that can add to the bodily burden of chemicals and create even further illness. And it's just really inappropriate because it doesn't address the problem. Is this something that folks with long COVID deal with?
Yes, definitely. And people with other contested illnesses, such as MCS, but also ME/CFS, chronic fatigue syndrome. There's a lot of parallels with people who have long COVID because fatigue is a major symptom for a lot of people with long COVID, just this overwhelming fatigue that is not actually improved by rest. Unfortunately, both people with ME/CFS and people with long COVID have often been so-called treated by healthcare professionals by saying, okay, let's do this exercise program and build up your strength and your capacity to move, to not have to lie around in bed all day, which is basically all they feel up to. But unfortunately, there is already a lot of research from people with ME/CFS, let alone more recently with people with long COVID, that kind of therapy is totally counterproductive and can actually lead to people having crashes and further exacerbation of their symptoms. But it seems to be one of the most commonly used therapies for people with long COVID, even though people with ME/CFS have been saying for many, many years now that it's counterproductive. And yes, you can use the term violence when those kinds of inappropriate therapies, whether they be medications or physical therapies, people are encouraged to do them because they do end up just having a negative impact on people rather than helping them in any way. It's the obverse of help. It's the reverse of help because it does end up often making their symptoms worse. So yes, that again, there seems to be quite a lot of medical ignorance going on here in terms of clinicians often seem to have no other options to offer people because there still isn't an effective treatment for long COVID.
Right.
So clinicians just seem to be casting around for what they already kind of have used for ME/CFS. It's just the more that people talk about their experiences with medical professionals, every study you read, just again and again, the ignorance and the lack of wanting to learn more about long COVID and to actually listen to people with long COVID properly and actually hear what they have to say. It just comes through again and again and again.
Yes. That really resonates. It seems shocking that clinicians, even when they're faced or met with so many people, so many patients with an illness like MCS or long COVID, choose to remain ignorant.
Look, I think again, I'm being super hard, aren't I, on medical professionals, but there's a, there's a, there is an arrogance that gets back to medical dominance, medical authority, epistemic justice, injustice, epistemic authority. And when you think about it, to be a medical practitioner, you kind of have to present yourself as authoritative because, again, this notion of trust, patients need, in the first instance, to trust your authority. Again, that is why they are there. They're seeking help for someone they would like to trust to have that authority, whether it's for a diagnosis, whether it's for, continuing prescription of medications that someone needs, whether it's a referral to a specialist. That is the point at which they're there for a reason. They are there for help. Patients are there for help. And if they could get that kind of help from, online patient communities, then they wouldn't be there seeking it from a doctor. But doctors are the gateways to a lot of this. They're gateways to prescriptions. They're a gateway to referrals to specialists. They're a gateway for, referrals for pathology testing. There's no other way to get that kind of treatment or diagnosis than from a qualified medical practitioner. And so people are forced to go, if they want or need those things, they are forced to go and see a medical practitioner. And it's all very well to say, well, patients can go and do their own research. But there are certain things that patients still need to go and see a medical practitioner for. I mean, even something like getting a doctor's certificate if you need to take time off work.
Do doctors diagnose people with long COVID, or is it similar to MCS where there actually isn't a diagnostic code and many just don't or can't?
Look, I think it depends on what jurisdiction you're in, what country you're in, whether there is an actual code, because it all wraps in with how people are funded as well, doesn't it, in terms of diagnostic categories, how the healthcare system is funded, how health insurance might pay or universal insurance might pay. I do know from reading people's accounts of their experiences that, yes, it is possible to be diagnosed with long COVID or whether it's called that or post-acute sequelae of COVID, the medical term. It is possible to receive that diagnosis. It is possible for a clinician to say to a patient, I think you have long COVID, or I think you have post-acute sequelae of COVID. People do get diagnosed, and for many people, a diagnosis, and again, this relates to other chronic conditions or contested conditions, for many people, getting a diagnosis, getting a label is important. Just having that label, having that diagnosis, knowing what the heck is going on with your body and your health can be incredibly psychologically validating for people in the first instance. But there is no, as I mentioned earlier, there is no actual, if there's damaging therapy that damages people, yes, that a doctor might then go and prescribe. But there's actually, once you've got the diagnosis, there is no actual, as yet, effective treatment or therapy. So it's great to have the diagnosis, and maybe you can use that diagnosis to get accommodations from work or at school. So that's valuable, or to get time off.
Yes.
Medical time off.
Yes.
And maybe you can get some referrals to some specialists. There's people with long COVID who have seen umpteen specialists, lots of different kinds of specialists. But again, those specialists have nothing to offer them as yet in terms of any kind of treatment or therapy, sadly. So the diagnosis gets you only to a certain point, which can be validating, but then after that point, there actually isn't anything that it offers you.
I think the accommodation piece that we rely on to get that diagnosis is very critical for many people. You write about the biographical disruptions. I don't have long COVID, but I imagine it's like MCS in a lot of ways, it just changes the way one fundamentally has to live. And it can often make us feel very apart from the dominant society. So how does long COVID change people's way of living?
Well, for those who have severely affected, I mean, it varies, obviously, there's a big spectrum of how badly affected people are by the symptoms. And some people, they fluctuate as well, bearing in mind, okay? So some days can be better than others. But for those who are really suffering from the worst impacts of long COVID, it can mean being bedbound, like totally bedbound, and just not having the energy to get out of bed and do anything. For some people, that can go on for weeks or months, or maybe even years. For others, they might have days like that, but then some other days feel a bit better, and they don't really know why, because again, we still don't really know what's going on with these symptoms. So, but yeah, at the most extreme, people can be bedbound for months.
Do you characterize this as a slow death?
Yes, I use the term at the very end in the conclusion of my introduction chapter, because, and it gets back to the fact that long COVID is a chronic condition. There is no treatment or cure for it. So people have died of it. Sadly, some people have died by their own hand because they feel so hopeless, but people have also died just because their illness just has overwhelmed them. Their body systems have failed them. I mean, it is fairly rare, but it has happened. For other people, it does just feel like a slow death because they can't see a light at the end of the tunnel. And it's slow because it's just gone on for years for a lot of people now. Since 2020, the first long haulers, or the first people with long COVID, early 2020, 6 years now, some people have had it with, again, no apparent improvement. So that's what I mean by a slow death. But I guess you could also, in social terms, it's a social death because they have to continue to be excluded from the usual social kind of parts of life.
Mm-hmm. And under people with long COVID, are many finding friendship, solidarity, support online with other folks?
Yes, and from the start, that has been, as I mentioned earlier, the particularly beginning on Twitter of all places, but also Facebook actually. So very early on, Facebook groups, special groups, people with long COVID were established in early 2020, and I do know that they are still going on, Facebook groups, support groups. In fact, Facebook actually has been, I've written about this before actually, Facebook groups are special groups, often they can be private groups or by invitation only, or you have to apply, so they're not necessarily always public groups, but there are a lot of them around for all sorts of illnesses, rare illnesses, for people with children with rare or serious illnesses, or for people who have them themselves, well before COVID. And so for COVID as well, and for long COVID, there's been a lot of Facebook groups.
Folks with MCS, we often find the same kind of support. There are many Facebook groups for people with MCS and in other online spaces, and they're very valuable. But what is the real benefit of these? Is it also a form of agency or collective agency, as you see it?
Yes, definitely. And we saw that with the beginning of discussions of long COVID on Twitter and on Facebook, where there was just a lot of, well, on Twitter in particular, it was a lot of public discussions, because Facebook, as I've mentioned, can be private groups. And often they are, for people with long COVID, they often are a private group. But on Twitter, it was a very public discussion in the first year or two of the pandemic, of people just drawing attention to long COVID and, talking about their own experiences very publicly. And I think in that way, the public aspect of Twitter was actually super important for people, because they could easily go on and look at the hashtags long COVID. There was a French well, various languages too. So yeah, social media actually was and continues to be a really important way of getting the message out, getting public awareness happening, and also drawing attention of health organisations and clinicians. And, they started forming groups with clinicians and writing journal articles about long COVID for prestigious medical journals like the British Medical Journal as well. So they actually managed to have a huge impact. And it all began on Twitter and Facebook.
Very interesting. As we perhaps wrap up, do you see any hope that research or public awareness could change the situation so there is no longer as much, or there's no more skepticism or medical denialism and dismissal?
I do see hope. And one reason for that is just the sheer numbers, given that COVID, as we were talking about earlier, is such a prevalent, nearly everyone has had COVID. So that means nearly everyone is at risk of long COVID, particularly if they keep getting COVID. And governments around the world aren't really doing anything to stop people getting COVID again and again and again. Obviously, long COVID isn't going to go away anytime soon. In fact, more and more people are going to be getting it, given that more and more people are continuing to get COVID infections and are at risk of long COVID. So I do think that just the sheer numbers are going to just, have impacts on society, on the economy. And there's researchers out there doing research on the epidemiology of it. So I do think there is hope, yes. Just the sheer numbers. Just the sheer numbers of people with long COVID will just mean that it can't be ignored for too much longer.
You've been listening to the Chemical Sensitivity Podcast. I'm the host and podcast creator, Aaron Goodman. The Chemical Sensitivity Podcast is by and for the MCS community. The podcast is generously supported by the Marilyn Brockman Hoffman Foundation and listeners like you. If you wish to support the podcast, please visit listen.chemicalsensitivitypodcast.org. Your support will help us continue making the podcast available and creating greater awareness about MCS. To learn more about the Chemical Sensitivity Podcast, follow the podcast on YouTube, Facebook, Instagram, Blue Sky. To learn more about the podcast, To learn more about the Chemical Sensitivity Podcast, follow the podcast on YouTube, Facebook, Instagram, Blue Sky, and TikTok. And you can reach me at aaron@chemicalsensitivitypodcast.org. Thanks for listening. The Chemical Sensitivity Podcast and its associated website are the work of Aaron Goodman, made possible with funds from the Marilyn Brockman Hoffman Foundation, supporting efforts to educate and inform physicians, scientists, and the public about multiple chemical sensitivity. The content, opinions, findings, statements, and recommendations expressed in this Chemical Sensitivity Podcast and associated website do not necessarily reflect the views and opinions of its sponsors.